Hi, good afternoon, everyone, and welcome to today's webinar, The Fourth Trimester, Is It Baby Blues or Postpartum Depression? With Dr. Debbie Rice, who's our Assistant Medical Director at Precision Analytical. My name is Amy Paoletti, and I'm a member of the Dutch Education and Marketing team, and I'd like to thank everybody for taking time this afternoon to be with us. I'd like to also invite all of you who are online with us that are connected with this webinar, if you don't currently have an account with Precision Analytical, to please contact our team, go to our website, learn how to become a provider. We offer a terrific opening order, offering up to 5 kits at 50% off if you're not already working with us. And then I just also want to mention a few housekeeping items before Dr. Rice starts. We will do our best to answer as many questions as we can at the end of the webinar. Please send your questions in either the question section in it should be the right-hand side of your screen, or through chat. And then I also want to let all of you know, if you miss anything at all, don't worry. We will be sending the on-demand recording out to everyone tomorrow, along with the presentation slides. So let me give you just a little bit of information or introduction with Dr. Rice. Dr. Rice is a naturopathic doctor who maintains a part-time practice here in the Portland area. She focuses on pediatric health, hormone health, thyroid health, and adrenal health. She's had experience working with communities in need, both in the United States and internationally. Her training has primarily been in women's health, pediatric care, and hormone therapy and hormone function, as well as complementary adjunct care. Dr. Rice utilizes multiple modalities, including diet and lifestyle, botanical medicine, and conventional approaches that meet the patient's needs where they are at in their health journey. Once again, Dr. Rice is the Assistant Medical Director for Precision Analytical, creators of the Dutch test. Dr. Rice's passion includes activism for access to healthcare, yoga, and exploring nature. So please welcome Dr. Debbie Rice.
Thank you, Amy. I'm so excited to be here. Yay. Well, welcome everyone. Today we're going to be talking about postpartum depression. And to get us started, what I'd like to do is, in order to understand the postpartum period, I think it's really important to understand what happens prior to postpartum. And so this is going to include pregnancy and all of its trimesters, along with that pre-pregnancy, or what I call 0 trimester, and prepping for pregnancy. And to get us into that mood, I'd like to take a stroll down memory lane. So here we can do a little fun thing.
Hey, Debbie. I'm not certain if everybody heard that. Do you have your headphones on?
Oh,
I wonder if they're hearing it through, are you hearing it through your headphones?
I am. Can you not hear it?
Yeah, I don't think the audience can hear.
Oh, here. Let's see. Can you hear that? Can you hear
I'm still unable to hear it.
wonder.
What did you just do?
I'm gonna see if sharing my screen here will make a difference.
Okay, that might. See the volume crossed out?
Yes. Can you hear that?
A little bit.
No. You can't hear that?
No. It's very, very. Sorry, everyone. We had
Sorry, guys.
previously and didn't have any difficulties.
Let me see here. But you can see this, right?
We can see it, yes.
But you can't hear it. Well, that's exciting.
I'm wondering if you unplug your headphones and try to play it again, if that will make a difference from your laptop.
Let me see here. Can you hear that?
No.
Still no?
Still no.
Well, that's a bummer. Okay.
So we'll make sure we send this out to everybody.
What's that?
I said we can make sure we send the link out to everybody as well, so they can get an opportunity to watch it.
Yeah, so that link is going to be part of the actual slide presentation. I apologize, that's a bummer. The presentation was actually going through just pregnancy and the different trimesters of pregnancy. So that link will be available when you actually get the slides. But the whole reason why I wanted to show that was because in essence, this is going through showing how all those 9 months of building a baby, nurturing a baby, right? So your whole body spends so much time making and developing this little human, at which you pop out eventually at 9 months. And the reason why I wanted to show that is because your body works really, really hard to do that. And so in those 9 months, you have spent all of your energy, all of your cells, all of your little enzymes making this, like you built a human. Like just think about that. You built an actual human. You nurtured and fed this little tiny human for 9 months inside of your body. And then you labored really, really hard to meet this little one. And so then what happens? You get what I call the Wonder Woman trimester. So this is another part of the trimesters that I like to talk about, because once you have this baby, you should feel like Wonder Woman. You are powerful, you are wonderful, you've made a human. Now, it's variable depending on how long this may last. It could be 10 minutes, but it could also be up to, 24, 36 hours. But yes, you should feel like Wonder Woman. Through pregnancy, one of the things that we look at, right, like as I count pregnancy out, we have 5 trimesters. We have the 0 trimester, and the 0 trimester is where we're looking at getting you prepped for pregnancy. Then we have your first trimester, second trimester, third trimester, and birth. And that puts us into our 4th trimester, or our postpartum. Now, this picture shows a really sweet representation of the process of pregnancy through the different trimesters until we get the mom holding the baby, smiling up at her baby. And as beautiful as this presentation is, this portrayal can be sweet, but it can be a little bit misleading, as it can oversimplify a very, very complex process. So understanding pregnancy through the 0 trimester. So in general, when we're looking at the 0 trimester, optimally, we want this trimester to be about 3 months if we can. Sometimes you don't get 3 months, which is fine. But when we're looking at the 0 trimester, these are things to consider when looking at postpartum, right? So things pre-pregnancy that we want to look at are what is going on with mom's stress, what's going on with sleep, How is her diet? What are her, what are the nutrients that she's getting? What's her nutrient support? What is her environment like, right? Not just stress, but also where is she? How is her cycle? Is her cycle regular? What is her motivation and energy like? How is her mood? Does she have any history of any kind of mood disorders or mood issues? Was she previously on birth control? And looking at all of the hormones involved with the 0 trimester, right? So we have thyroid, cortisol, estrogen, progesterone, testosterone, DHEA. Insulin is also a big one here too. Once we go past that pre-pregnancy, we get into the first trimester of pregnancy. So we have, all right, we're pregnant now. What happens? So pregnancy cannot happen without estrogen, specifically estradiol. So when we're looking at estrogen, estrogen is important. It helps to stimulate ovulation. Without estrogen, we can't ovulate. Estrogen builds up that endometrium, so it helps build up that the endometrial wall. And then progesterone helps to aid in the implantation of the egg into the endometrium. So you have this little egg that gets fertilized, and the progesterone helps that egg get into that endometrium so it can plant itself in there. The progesterone also tells the body to stop menstruating, right? Like, okay, we have pregnancy, let's not bleed anything out. The other hormone here in the first trimester that's very important is the HCG hormone, or the human chorionic gonadotropin hormone. So HCG actually supports the development of the egg inside of the ovary before it pops out of the ovary. HCG eventually forms the placenta once that implantation occurs. And HCG is responsible for helping to get that progesterone production until that placenta is formed. So your estrogen levels increase significantly starting in that first trimester. So as soon as you are pregnant, as soon as that egg becomes fertilized, you start to get high levels of estrogen going through. Estrogen is also important throughout pregnancy because it helps to signal development of organs in the baby. So if you don't have sufficient estrogen, you can have issues with organ development in the baby. Progesterone induces a protective mechanism in the endometrial lining. So this helps to ensure that that embryo can implant. It keeps it protected so that that embryo can implant into the endometrium. And progesterone also helps to suppress uterine contractions so that your body stays happy and smooth. Nothing is, forcing anything out. HCG, so this saves the corpus luteum from involuting so it can continue to make progesterone. And a quick tangent on that is corpus luteum involuting. What does that exactly mean? When we're looking at ovulation, right? So we have your little follicle here is trying to build up an egg. And so your little follicles through the cycle in that follicular phase is helping these follicles develop. And the job of these follicles is to help build this egg. This dominant follicle, or what we call the mature follicle, ends up popping out an egg. Once that egg goes out into the fallopian tube, we have remnants of what are called the corpus luteum. And if we have pregnancy, we want this corpus luteum to stay alive. And the way that happens is that HCG continues to signal this little corpus luteum to stay alive to get that progesterone going. So going back here, that HCG helps keep that corpus luteum from dying, and it helps to continue to push that progesterone production. So it saves that corpus luteum, and this HCG continues pumping out until the placenta, so the placenta starts to grow as soon as we have implantation. And as soon as the placenta is big enough, then it can take over progesterone production in pregnancy. The placenta is actually a pretty amazing organ. It ends up creating a lot of its own hormones, which we'll talk about throughout this webinar, but HCG is very important in that. I wanted to show estrogen levels here so we can understand how significant these estrogen levels are in general. So in females, when we are in our follicular phase, we have varying levels of estrogen. So in the follicular phases, we're developing that little follicle, we're trying to make that egg. we can have levels of up to 100, later in follicular phase 400 of your estrogen level, up to 400 here. When you are pregnant, look at this. You go from, in the hundreds to like the 2000s. In your second trimester, you can go up to 7,000 with your estrogen levels. In your third trimester, you're still up there pretty high in the thousands. So when we're looking at these levels, that estrogen is really, really high. Same thing with progesterone. So when our body is looking at, developing that egg, our progesterone is actually really low. Prior to ovulation and during ovulation, progesterone is quite low. Once we ovulate, we try to get a nice little push of progesterone there. We like to see progesterone, probably closer to the 20s to get that nice ovulatory push, which means we have that good progesterone picture. If we look at what's happening in the first trimester, second trimester, and third trimester, again here, our progesterone levels are significantly higher. Like now, instead of being in the 20s, we're in the 200s, right? We're in the hundreds, 200s for our progesterone levels at the end of pregnancy. Side note on progesterone and why progesterone is also very helpful in pregnancy. It's been found to be fundamental in reducing the rejection of the trophoblast or that embryo. So the progesterone actually signals to the body with these little cytokines. So these are little hormones, these cytokines, which can create what's called a Th2 response. And these particular cytokines actually encourage the placenta to make HCG, to make that progesterone, so that we can keep that embryo safe. And when we have Th2 dominance from this progesterone, it encourages that implantation. So it helps to not reject that implantation. So that's where progesterone is also very helpful. If we don't have a happy, healthy implantation place, pregnancy may not happen. And so that's why progesterone can be very important here. So when we have this cascade of hormones in delivery, we've had, pregnancy, we've gone through first trimester, second trimester, third trimester. We have this big push of estrogen, we have this big push of progesterone. Remember, estrogen in the thousands, progesterone in the hundreds. Many, 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 many hormones happening here. There's a gentle push of hormones that change leading up to labor. Right, so relaxin is one of the hormones. It kicks in to soften the bones and cartilage in mom before labor starts. Then prolactin starts to increase. And then in a short time period, which can be quite variable, for some people it's only hours, for other people it can be a few days, but the baby initiates these signals. So baby initiates this other release of cortisol through baby's hypothalamic pituitary adrenal communication. This causes an upregulation of oxytocin receptors in the mom's endometrium, myometrium, and her uterus. This causes a drop in progesterone production. So all that, hundreds of level of progesterone ends up dropping. Consequently, because you have estrogen in the thousands, remember, this creates estrogen levels that are higher, creating estrogen dominance. This estrogen dominance also helps to set off a release of prostaglandins, which can be somewhat inflammatory, but it helps with uterine contractions. So those uterine contractions are what lead to that birth and delivery. And now we have entered that postpartum period with a little sidestep into that Wonder Woman period. So the postpartum period in general is typically allotted about a 6 to 12 week time period. It can last up to 4 years or more. Now, when we have this postpartum period, it can mimic menopause, but pretty drastically and quickly, because there is that sudden drop of estrogen and sudden drop of progesterone. Now, we also have oxytocin, right? So oxytocin tries to calm the sting of that big let out of estrogen and progesterone. And oxytocin makes you really love this little baby that's responsible for all of this, right? So oxytocin tries to help out here. With the postpartum period, we have significant progesterone drop, estrogen drop, oxytocin rises in pulses. So it's not like you get this consistent oxytocin level, right? So it's not like all of a sudden you just replace estrogen, that drop in estrogen and progesterone, with this consistent rise of oxytocin. it pulses with nursing and lactation. Prolactin levels increase. And the reason why prolactin levels increase is because this actually becomes inhibitory for progesterone and estrogen. So prolactin is actually helping to keep that estrogen and progesterone down so that we can have oxytocin available, so that oxytocin can help mom with nursing baby. Now, when we look at postpartum, we want to look at what postpartum means. What does postpartum depression mean? So according to the CDC, postpartum depression is actually depression, right? So when we look at depression as a definition, and I'm just going to list this is from the CDC. So this is what depression is: lasting sad, anxious, or empty mood, feelings of hopelessness or pessimism, feelings of guilt, worthlessness, helplessness, feelings of irritability or restlessness, loss of interest in hobbies and activities, loss of energy or fatigue, problems with concentration, difficulty recalling details, making decisions, difficulty falling asleep or sleeping too much, overeating or not eating enough, like loss of appetite, thoughts of suicide or suicide attempts, and possibly aches or pains that do not get better with treatment. Now that is depression. Postpartum depression is all of those things with the bonus of these additional things for postpartum depression: crying more often than usual, feelings of anger, withdrawing from loved ones, feeling numb or disconnected, worrying that you will hurt the baby. This is actually a big one that people reported for postpartum depression, and feeling guilty about not being a good mom or having the ability to care for your baby appropriately. So that's a pretty big list, and that's pretty significant when we look at that effect of what postpartum depression can be. The incidence of postpartum depression. So there are various sources that have various answers. According to the CDC, 1 out of 10 women suffer from general depression. And general depression itself can be a risk factor for postpartum depression. 1 in 8 women suffer with postpartum depression. That's a lot, right? 1 in 8 women. If you think about how many women that you know that are pregnant, 1 in 8 of those women can suffer with postpartum depression. But this can also vary depending on the state and location in which you live. So depending on how you live, where you live, your socioeconomic status can possibly push this level to 1 in 5 women that suffer from postpartum depression. Now, the big thing that we want to know here is this postpartum depression, or are these the baby blues? So depression, for postpartum depression, this is much more severe. The onset is usually within the first month after birth, and it lasts longer than 2 weeks. To fall in that true definition, it has to last longer than 2 weeks. Now, this can last up to 4 years or more. And so this is where I feel like research has somewhat failed women. Like, we've been delivering babies for, pretty long time. It's something that happens a lot, and it's been very looked over in the world of research. Certain studies show that depression and anxiety are common in moms with preschool aged children. So a lot of moms think like, wow, I have a kid, my kid's 4, my kid's 3, my kid's 5, but why am I still suffering with depression or anxiety? And this can be linked to postpartum. Now, baby blues can happen up to 85% of new moms, right? This is short term, it's transient, it usually lasts for maybe a week or 10 days. And this is, when we look at just the swing of things that happen when you're pregnant, all of a sudden you have a baby and you come home with a whole other human. And in all of this that's happening, you're trying to figure out how to nurse. You're trying to figure out when to nurse. You're not sleeping, right? You're trying to figure out, okay, baby's up, baby's asleep. Wait, should I be sleeping when the baby's sleeping? Wait, what do I do for food? I'm trying to nurse the baby. I'm trying to figure out am I nursing right? What's going on? I also haven't showered for 5 days. I don't know what to eat. I don't know how to make food, right? Like, that's a pretty big thing to consider especially if it's your first baby. But even, just because it's maybe not your first baby doesn't necessarily mean it should be easier, right? A lot of these things change when you bring a new baby home. And so it's not uncommon for there to be this transient baby blues period, but postpartum depression becomes more long-term or chronic. So when we look at postpartum depression, we want to look at the why. And these are the big risk factors for postpartum depression. So major mood disorder prior to pregnancy and or during adolescence. So a lot of research showed adolescents or teenagers that struggled with significant mood issues have a high risk for postpartum depression. Stressful or significant events before and during pregnancy can absolutely be a risk factor. Anxiety in general, insomnia and circadian rhythm abnormalities, right? Like if you don't have a good sleep-wake cycle, that can influence your hormones and how your hormones respond. Your socioeconomic status can be a risk factor. High levels of testosterone can be a risk for postpartum depression. Low levels of oxytocin. Hormone changes in general, when we look at thyroid function, neurotransmitters, cortisol. History of significant PMS. And when we look at this, PMS, this is going to look at significant variations in estradiol and progesterone. So if you have more consistent levels of estrogen and progesterone, that's going to be different than significant swings or variations in estrogen and progesterone. High stress, and just the natural drop in hormones for your estrogen and progesterone can be a risk factor. Postpartum, the why. And so when I look at this, it takes a village, and at least our modern world is not very village friendly, right? So when we look at your environment and your lifestyle and as a contributing factor to the why of postpartum. So you have a baby, all of a sudden there's this new human. For some people, it can be a loss of self, right? Now, everything that was you before is caught up and taking care of this little human. And, I've had lots of moms say, all of a sudden I'm just this thing, even when I go over to my parents' house or I go over to see my family, all they want to see is the baby, right? So you lose that recognition as you being a person. And it's also like I'm just a milk machine, right? So you're just nursing and you're trying to keep your calories going so that you can feed this baby. So there is a big loss of self with that. Loss of socialization. So I can't tell you how many times, I hear friends or even moms say, my friend group said that things are not going to change, everything's going to stay the same, but it can be very different when rubber meets the road, when you come home with a baby and you have people that are still going on with their normal schedule. And so that can be very isolating, right? Like if you are home alone, you don't have a lot of family, you don't have a lot of friends, and all you have is this little baby who you're still trying to figure out how to communicate, right? Like this is the most complex roommate situation you've ever been in, right? You have this new roommate. The only way it knows how to communicate with you is by crying. Like what? Yeah. Okay, that's going to be a little bit stressful too, like trying to figure out all of those signals while still trying to take care of you. That's a big thing. Loss of sleep. And, definitely consider the possible aftermath of traumatic births. So when we look at moms who have certain expectations going into birth scenarios, or if something traumatic happens no matter how you define trauma, if you have a traumatic birth, that can influence your why for postpartum depression. And loss of family support or loss of overall support network. And even if your friends are like, hey, we're so excited for you, yay, just let us know what we can do. When you are overwhelmed, right? Like when you're in the waves, it's really hard to pull yourself out of the waves to be able to know which direction to go. And if you feel like you're overwhelmed or drowning in that, it's hard to tell your family what you need. And so if your family is more of like, well, reach out when you need help, it's going to be hard to let them know. And so you can have that loss of family support or social support, and it may not be intentional, but it can just happen. And this is where, again, it takes a village to help women feel like they're not losing their self, they're not losing their socialization. Maybe they have somebody that can help them so that they can get more sleep, or they can take a shower, or they can do the dishes. As far as postpartum and the what, so there are lots of hormones involved in the what of postpartum. So we have your sex hormones. Again, that's your estrogen, progesterone, testosterone, DHEA, your adrenal hormones, which are also DHA and cortisol. We have thyroid hormone. We also have some neurotransmitters that play a role here. So that's a lot of hormones, right? Like even if we were to just deal with one of those, that's a lot. But postpartum, we're dealing with all of those things. So when we're looking at thyroid function, thyroid is actually the main controller of metabolism. Pregnancy puts a very high demand on the body's metabolism, right? So when you become pregnant, your body gets the signal of like, whoa, all right, we have to upregulate things because we're now building another human. So your body, I mean, this is where you get like increased blood volume. This is where you get more hormone output in general. Once you deliver, thyroid function should return to pre-pregnancy levels within 4 to 6 weeks. A thyroid hormone in general, or thyroid imbalances, can already contribute to mood dysregulation. It can affect your mood. It can influence depression, anxiety, and fatigue. Because of the big changes that happen with pregnancy, it can exacerbate this presentation. Common presentations of thyroid imbalance include hyperfunction. You know, your body is still just kind of rolling with, all right, we're just pushing everything out, hyper, we need more, we need more, we need more. You can also have increased autoimmune thyroid reactivity. So this is where in pregnancy, because certain things get signaled, a lot more autoimmune signals can happen, or autoimmune diseases or presentations can show up because of pregnancy. You can also have a hypothyroid due to some estrogen dominance with pregnancy. And if you also, I mean, as you deliver and your body is trying to rebalance itself, it may show up as hypo as well. Now, up to 23% of new moms experience low thyroid. And like, once baby is born and your body is not contributing to thyroid function for the baby, you might get mixed signals, or your body's just tired, and that's where you get this lower presentation of thyroid hormone. Research has also shown that elevated TPO levels, or thyroid peroxidase levels, which is the marker for Hashimoto's, have a higher risk for postpartum depression. And this is especially in the presence of low thyroid hormone. So if you have Hashimoto's, whether because it happened during pregnancy or if you had Hashimoto's prior to pregnancy, that does set you up for as a risk for postpartum, but even more so if you also have low thyroid hormone production or low thyroid hormone availability after delivery. So that's something to, you know, either as a patient or as a provider, you need to be aware of. Now, cortisol. Cortisol, we know, is complex in general. Cortisol increases steadily during pregnancy. So this is generally upregulated because mom gets the signal of like, all right, like we need more hormones. But this is also influenced by the baby. So after birth, when cortisol levels remain imbalanced, whether it's too much cortisol or too little, this can be a major contributing factor to postpartum depression. Now, the details on this are because the placenta actually ends up becoming its own little hormone factory. In the placenta, there is something called corticotropin releasing hormone. And this is where, you know, like the baby's doing all of its own little things. So you have this little human that's creating all of its own little hormones there, right? So this corticotropin releasing hormone actually signals to the baby as well as the mom to make more cortisol, right? So baby's actually influencing, you know, its own cortisol production, but it's also telling mom's brain to make more cortisol. So that's also part of why mom is making more cortisol. Like if we test a mom during pregnancy, generally we're going to see high levels or increasing levels of cortisol. If you had somebody that had low cortisol levels before pregnancy, you actually might see them come into normal levels, but it's still higher levels of cortisol. So when we look at cortisol, research shows that the HPA axis, or the hypothalamic pituitary adrenal axis dysregulation, is common with pregnancy. So when we're looking at what is a normal diurnal rhythm, what we're seeing is we want to have that cortisol shoot up and get you ready for your day, and then come down through the rest of the day to get you ready for sleep at night. And it's not uncommon in general through pregnancy to see that this diurnal pattern becomes dysregulated. Now, is it because that baby is doing stuff? Sure. Does a baby follow a diurnal pattern? You tell me, right? Like when baby's born, baby is asleep, awake, asleep, awake. And so that's not a normal diurnal rhythm. So is that being influenced by the baby? High possibility, yes. So after pregnancy, after delivery, cortisol in the mom responds to ACTH signaling. And so mom's body is trying to manage cortisol through ACTH signaling. The baby is also sending out that corticotropin releasing hormone, which is also telling mom to release cortisol. Because the placenta is creating more of that corticotropin releasing hormone, mom's creating, more cortisol, the placenta essentially overrides mom's signaling through ACTH to produce cortisol. Therefore, when baby's born, placenta is also delivered. So that little hormone factory is removed. That signaling for cortisol production is also removed. But in this 9 months, right, mom has had this suppressive effect on her ACTH signaling. So mom's ability to make ACTH has now been suppressed for, about 9 months. And now her own cortisol production is low or lowered. And so we see this drop of cortisol. And so this can influence that cortisol awakening response and that diurnal pattern where we want to see that cortisol rise in the morning and drop throughout the day. Now, what we already know in general research is that cortisol awakening response, which is that very particularly first initial rise in cortisol in the morning, correlates pretty strongly to major depressive disorder. We just know that in general. Now, if we take this in consideration with what we know now about mom and baby signaling for mom's cortisol, we will see a low cortisol or that low waking cortisol response in the morning. And research has shown that this suppressive effect can last up to 3 months for women postpartum. So that's pretty significant. And that is really common in the research. It's very common. So it's a very important component of evaluating either prior to pregnancy or after pregnancy, right? Like when we're talking about that preconception or that 0 trimester, right? If we have somebody that we're trying to get pregnant, why not check out their cortisol production before they get pregnant so we know what's happening with their cortisol awakening response, what's happening with their cortisol signaling right now, because that's really going to help us understand what happens after, right? Now, there's not a lot we can do during pregnancy because pregnancy is its own magical wonder. But after delivery, if we have a good comparison for baseline, that's going to be even more helpful. So the other exciting part of cortisol is cortisol and kynurenate have a little love affair. And so kynurenate ends up being a metabolite that builds up when the body is not able to push kynurenate. Kynurenate helps in making serotonin. I'm totally skipping on a word here. But kynurenate helps to make in the pathways tryptophan to serotonin. So when you have increased cortisol levels, increased cortisol can be correlated to increased immune inflammation. When we have increased inflammation, your body ends up, instead of pushing tryptophan to make serotonin, it pushes tryptophan to make kynurenate. And what that looks like here is that instead of tryptophan going down a tacky little pathway to serotonin, which is our happy hormone, we end up pushing it to kynurenate, and kynurenate can create neurotoxicity or oxidative stress. And so not only are we getting more oxidative stress, but we're getting less serotonin. So when we look at this, it's a double whammy, right? Like our body after birth is like, okay, well, we've lost estrogen, we've lost progesterone. Hopefully we have some good oxytocin going on. But if there's inflammation and stress, our body is not now making serotonin either. So that ends up being more of like a triple whammy, right? No estrogen, no progesterone, and now no serotonin. So that is a big influencer in that feel-good hormone for serotonin. The other complicating factor here is estrogen is necessary for serotonin production. And so when we have that drop of estrogen at birth, we don't have the estrogen necessary to help with that conversion to serotonin. And serotonin is that feel-good, calming hormone. It helps with sleep, right? So that loss of estrogen further reduces our body's ability to make serotonin. So we kind of get set up to be depressed after we deliver a baby. I mean, oxytocin, we're really putting a lot of faith in oxytocin and hoping that cortisol is also doing its job. But given the high level of stress just in our world in general right now, can be very difficult to know that that's going to happen. So with oxytocin, if we don't get enough oxytocin, that can set us up for postpartum depression. Low oxytocin can happen with high stress or high cortisol, right? So if the body is dealing with high stress, your body doesn't get the signals to release a lot of oxytocin, and that can be a risk factor. Now, early life trauma can reduce oxytocin levels in general. So if you were a kid, you had high trauma, that can already put you at risk for low oxytocin levels. One of the things that can reduce oxytocin as well after birth is oxytocin receptor hypermethylation. So that means that we have fast clearance of oxytocin, so it doesn't stay around for your body to use, right? Your body, it just ends up with hypermethylation, it just ends up clearing that oxytocin away and it's not used. Now, women, there are some studies that show women that are exposed to synthetic oxytocin or Pitocin. So if you're in the hospital and they're giving you Pitocin, and this doesn't happen to everyone, but if you get Pitocin, it can give you a higher risk for postpartum depression, because what ends up happening is you're getting Pitocin, right? So your body down regulates its own production of oxytocin. So you're not getting that surge of your own production of oxytocin, which again puts you at lower levels of oxytocin. And when you don't have that oxytocin, that feel-good hormone, you don't get that kind of balance, right? Remember we have that drop of estrogen, drop of progesterone. We expect to have this increase in oxytocin. If that doesn't happen, that will also set you up for mood stuff, as well as, it can complicate nursing. And when we have those complications, it can also make it more frustrating, and it can further feed the fuel of not being able to, are you doing the right things for your baby? Are you creating milk for your baby? Can you take care of your baby, right? So it creates just this kind of cyclical issue. The other component here is testosterone. So high levels of testosterone are found in women struggling with postpartum depression. This could actually be a predictive marker to check for moms that you think are high risk, right? So if you know somebody that's at high risk for postpartum depression, it may not be a bad idea to do a serum check actually of testosterone within 24 to 48 hours after birth and see where their levels of testosterone lie. High levels of testosterone, for whatever reason, are a risk for postpartum depression. Now, when we look at that, just in general, we think about testosterone and its balance with estrogen and progesterone. That could be part of it. We also want to evaluate, insulin and PCOS as risk factors in testosterone levels for postpartum depression and risk. So this is where we go from that, Wonder Woman feeling, which is absolutely amazing, to feeling crashed, and then you have mom zombie, right? You're just trying to make it through the day. Now, when we look at postpartum options for treatment, we have to remember we can test these hormone levels, especially if you are able to get the care that you need prior to pregnancy, right? So let's test your levels before pregnancy. Let's test your cortisol. Let's test your estrogen, progesterone, testosterone, insulin, thyroid. We can look at your kynurenate. We can look at all of those levels, right? Things that can help reduce postpartum issues. Cognitive behavioral therapy has actually shown up in research to be very supportive. It can reduce the symptoms or the intensity of postpartum depression. It's a very, very helpful therapy. There is varied research regarding oral progesterone supplementation. So when we look at oral progesterone supplementation, what we find is that oral progesterone does stimulate the allopregnenolone, or that allo or alpha presentation in progesterone. It stimulates the GABA receptors in the brain. And GABA is that also like feel-good hormone. And so with people that struggle with anxiety and depression, that GABA support can make a big difference. Estradiol supplementation may also be helpful, more so that we can get that serotonin support here, right? So we know we have that drop in estrogen. If we're lacking in serotonin, it may help to improve that serotonin production. Now, we want to make sure that we're also addressing any kind of inflammatory issues, any kind of autoimmune issues, so that we're not pushing that tryptophan to kynurenate. We want to help support that tryptophan to serotonin production, and serotonin consequently helps to make melatonin. So those are also going to help with sleep and calm. We want to evaluate nutritional status and vitamin levels. So I don't ever, like, once mom is pregnant, placenta is going, like, that baby is a machine, right? Like, it is a very, very effective parasite. And I mean that in a good way. Like, baby is going to get what baby needs, right? Baby's going to get all of the nutrients that mom has. But that means that mom loses out on those nutrients with pregnancy. And if this is her 5th pregnancy, goodness, I want to make sure that she's got good hormones going in, like she's got a good robust hormone presentation going in, balanced, and that she's got good nutritional status, right? Like, we have to have good nutrient status to get all of those substrates so that we have all of those enzymes being able to convert everything that we need. We also want to look at stress management and cortisol optimization. There are prescription medications. And so when we look at treatment for postpartum, and this is going to be a very big consideration, if mom is at the point of big concern, I want to make sure that we're taking care of mom, but it's always going to be a risk to benefit ratio on if they're taking medications or not. General prescription medications are the first line therapy is sertraline. This is less risk to the baby while nursing. That is first line therapy. If sertraline does not work, your second line therapy is going to be fluoxetine or nortriptyline. But first line therapy is always going to be sertraline. There's another medication called brexanolone. This was recently approved by the FDA. It's a synthetic allopregnenolone. So it's that one that helps push that alpha response, or that allo response, to initiate that GABA response in the brain. So it's a GABA mediator. Now, the problem with this is it can be financially prohibitive. It is an IV medication. There are not a lot of clinics that are practicing the use of brexanolone because it is so expensive and because it's an issue with getting IVs in there, getting insurance to approve it. And that's where, again, like, oral progesterone may be a better option versus something like brexanolone. We also want to look at lifestyle and socioeconomic status. So when we're looking at this, this is also about access to medical care. And when we're looking at postpartum, when we're looking at socioeconomic status, I know that we're in a system, right? So this can be very difficult, but when we're assessing risk for somebody, we want to look at what their availability is to creating availability for testing and evaluation before getting pregnant. We want to look at their availability, that during pregnancy, they're able to get the support that they need, right? Because remember, high stress and traumatic events during pregnancy can be a risk for postpartum depression, as well as after delivery, right? Like, do they have a safe place to go? Do they have a less stressful place to go after birth? So one of the things that I also think here is, as a provider, I know that we want to look at, well, we'll talk about evaluation first. So testing and evaluation is going to be important. And the beautiful thing is the Dutch test actually tests all of the things that we're talking about. We look at estrogen levels, we look at progesterone, testosterone, we do test kynurenate, we test melatonin, we test cortisol, we have the dopamine metabolites, we look at oxidative stress, we test all of these things, right? Looky there. all of those different levels are in a Dutch complete or a Dutch plus. If you're looking at a cortisol awakening response, that's going to be our Dutch plus. So when we're looking at postpartum evaluation, we want to look at timing of the test. So we get a lot of questions like, hey, I just had a baby, how long should I wait for testing? Depending on what your risk evaluation is prior to pregnancy, I would say you can do cortisol testing as soon as you have that baby, right? Like we can test right away, look and see what's happening with your cortisol, what's happening with your melatonin, what's happening with your kynurenate, right? Like what is happening with those levels? The variability of results is going to depend on where you are postpartum. Are you nursing? How long have you been nursing? And what is your prolactin doing, right? So when we're looking at prolactin, this is looking depending on whether your body is able to produce milk, how much milk you're able to produce, what your job situation is, right? Like, are you able to take the time to nurse or not, or even, get milk frozen for your baby? What does that look like? Prolactin suppresses that estrogen progesterone response so you can nurse, but we don't have great research on how suppressive prolactin is or for how long it is. And you'll have some of those, some women are like, oh yeah, I started my period 2 months after I delivered. And then you have the other woman who didn't have a period for 2 years. Now, does that mean that those prolactin levels are the same? Absolutely not. Every person is going to be a little bit different because prolactin is also going to be responsive to oxytocin, which is going to be responsive to stress and other hormones. So there is quite a lot of variability in when you can do testing. And I would say if you are having symptoms, that's when you do testing. So I have a couple of case studies here. So this is our first case study. We have 3 different times here for what a Dutch test looks like for somebody who is postpartum. This person is breastfeeding. She is not cycling. She is 4 months postpartum. What we see is she's got that nice prolactin suppressive effect on her estrogen and progesterone, but her estrogen is still kind of sneaking up there. Her testosterone is not high. Her DHEA is hanging in there, and her cortisol picture, she's got sufficient cortisol. She's got a decent cortisol awakening response, but we can see that suppressive effect on her progesterone here. Now this person still breastfeeding, but now she has been cycling for 6 months. She's got a really robust estrogen, decent progesterone. Her testosterone has increased here, but we also see an increase in DHEA, right? So this is where we start to see that prolactin, even though she's still breastfeeding, it's not having that same suppressive response. We still have her cortisol, which is a little bit more robust here. So cortisol production is increased. She still is showing a really nice diurnal presentation. So she has this nice rise and fall in the morning and then lower in the afternoon and at nighttime. And then this next testing is she has now stopped breastfeeding 8 months prior. So she is back to her normal of her estrogens, progesterone, and testosterone. And this woman just by herself makes a lot of estrogen. So this would be very similar to her baseline. So after stopping breastfeeding for 8 months, she is pretty much normalized back to where she was prior to pregnancy. So again, it really depends on the person, what their prolactin is doing, how their body is reading their prolactin, and how suppressive that effect can be on the estrogen and progesterone. A different case study, this person is 9 months postpartum, still nursing, and she had 1 cycle irregularly before we did the Dutch test here. We can see she's still getting a little bit of a suppressive effect on her progesterone, but not on her estrogen. So that alone, like even if we were to not even look at postpartum or nursing, right? She now has a little bit of estrogen dominance, not because she has crazy high levels of estrogen, but because she doesn't have a lot of progesterone. And that can also set you up for lower mood, anxiety, sleep issues. So evaluating those hormone presentations, I think, is important when you're evaluating mood. Her testosterone is not elevated, but her DHEA is fairly robust. When we look at her free cortisol pattern, right, we see that morning response for her is low. And we just learned that low cortisol awakening response in the morning can be a risk for postpartum depression. And there we have it. So when we look at postpartum considerations, so the statistics for postpartum depression are significant. Included in postpartum depression is also the risk for suicidal ideation. And one of the things that I wanted to point out here is suicide is the leading cause of maternal mortality. And that is not, like when we look at maternal function, postpartum depression, this is not a huge thing in the news, right? This is not covered well. This is not studied well. And this is something that has been happening for thousands and thousands of years. This is definitely a hole in research, and we really need to put more effort in research, I believe. One of the things to also consider when we look at the statistics for postpartum depression are that postpartum depression can significantly affect the neurocognitive development of the child as well. So given moms, like the ability for a mom to be able to bond with her child is also a big effect on the baby as they grow up. Now, resources to manage postpartum depression, these are limited. And the big part about this is, again, we have kind of failed our women with regard to research and what we have available in that area. But the other thing is, like, postpartum visits for mom are very few and far between, right? Postpartum visits are usually just one right after birth. And then the next one may be at 6 weeks. You might not have it for 2 months. You might not have it for 3 months. And if we have postpartum depression, even baby blues happening within 2 to 6 weeks, we don't have a professional that's checking in on what is going on with mom. So this time range doesn't allow for sufficient evaluation of a mom who may be struggling with postpartum depression. Now, as a practitioner, I would say if you deal with, getting people pregnant, if you deal with delivering babies or even pediatrics, right? Like, this is where I would say you can hopefully offer options for, like, I know you just had a baby, but let's check in. We know that your risk is here. So having that frank discussion of, we know that you have a risk for postpartum depression. We know, given all of these things happening either as you were growing up or before pregnancy or during pregnancy, I'm going to make a plan to meet with you a week after delivery, 2 weeks after delivery, 3 weeks after delivery, whatever that looks like for you, to be proactive. Now, if you're a patient and either you previously have had issues with postpartum depression, or that there's family history, or some of these things come up for you that you're like, yeah, that puts me at high risk for postpartum depression, talk to your provider. I think it's really important the hard thing is you will have to advocate for yourself, but it's really important to have this discussion, because I would rather know that you are being seen. I would rather make the time to see you than have you kind of swimming around in this like murky area of like, well, it's stress and I'm not sleeping, and every mom goes through this, right? As common as it may be, there are resources to help you out. So don't just try to go it alone. Counseling and lifestyle support have shown to be supportive and effective. Again, cognitive behavioral therapy kept coming up multiple times and shows really great response in research for reducing intensity and frequency of postpartum depression. And if it's unavailable, right? Like if these therapies are unavailable due to lack of resources, as a society, I would love to be able to figure out a way to create availability or even awareness for availability for these resources. Again, as I said, as a patient, having a frank conversation with your provider, or if you're a provider, having this in your awareness to know, like, okay, a lot of these things are coming up. You can determine your schedule. You can work with your front desk or your office to create a program to offer that awareness and availability. I think that's going to be a big plus. These are my references. And again, because the Dutch test offers, we get so much information from everything that I just talked about. Doing any Dutch testing, whether again it's the Dutch Plus or the Dutch Complete, are an option for you. And that concludes our talk.
Thank you, Dr. Rice.
Yeah.
So I have several questions that we'll try to run through here real quickly.
Sure.
Are you ready?
I'm ready.
Okay, so a lot is, as you might imagine, a lot of our questions are centered around testing, breastfeeding, and some of the treatment options that you talked about. So one of the first questions I have here is, should we wait to run labs until after a mom stops nursing?
I don't think so. I mean, the challenge with this is how much intervention or treatment can we do, but it depends on how intense mom is suffering, right? But if she has symptoms, test.
Okay. Do you know if the placenta is left attached until the cord falls off naturally, would this change the level of hormones in the mother?
No.
Okay.
Nope. You still get that loss of the placenta. So, I mean, even though you're still getting like a couple more minutes of that, you still have that significant loss of hormones.
So, Debbie, I know that you showed examples of both car results on a woman who's postpartum, as well just regular urine results. So I've got somebody asking if you could talk more about CAR and depressive disorder on postpartum, and maybe in both pregnant and non-pregnant females, what is the correlation there with the CAR?
Yeah, so just in general, and what I'll do actually is maybe go back to the visual slide for this too, here. So in general, a low CAR can be associated with major depressive disorder. And so that's not pregnant, just in general. If you have a low cortisol awakening response, it can be correlated to, not all the time, but it can be correlated to major depressive disorder. But go ahead.
No, you go ahead.
But the mom, so what we generally see, like if we are testing, like if we were to, based on the research, right, if we have these moms, they deliver, we do a salivary cortisol awakening response. In general, we see a low cortisol awakening response, which is going to look like the little green line here, this low cortisol awakening response. And that itself is telling us this is a high risk for postpartum depression in females.
So would you say in your practice, is your preference to do the Dutch Plus on your postpartum patients?
Yes. Yes, I mean, if they can't afford it and you were to do a Dutch Complete, you'll probably still see a low morning cortisol, like in the case study here, right? So this is not a Dutch Plus, but this Dutch Complete still shows a pretty low morning cortisol. And that tells me she's not getting that nice diurnal presentation, but it would be optimal to do a Dutch Plus. So you really get this picture where we can see like there's not even like, she doesn't even really rise up on that green line there at all.
So have you, if you've tested reverse T3, have you seen any pattern with this particular marker and any correlation of it being high and then postpartum depression in the women who have delivered?
I haven't done enough of that testing to honestly answer that, but I would say in theory, it could be because that can make thyroxine lower and not as available, right? So it possibly could, but I couldn't say absolutely.
Okay. Can you talk about contraindications for supplements postpartum, such as SAMe, GABA, adaptogens, thyroid support, to get someone's antibodies down and to help them with mood?
That's a big question.
I know, there's a lot of things in there.
Yes. So I will say, I mean, just as a caution, right? Like we have to be very careful with what we're supplementing postpartum if they are nursing, right? Because we don't have a lot of information on nursing mothers and the effect of like all the things that go through breast milk and everything like that. When we're looking at natural supplements, like something like SAMe or even herbs like ashwagandha, a general statement that I will say is when you're doing it in physiologic doses, that can be a consideration. Once we go supraphysiologic, that's where we start to see big problems, or where you can see side effects that are happening. Now, that said, thyroid hormone is considered safe during pregnancy and postpartum, and thyroid can have a major influence on, baby development during pregnancy. So you really need to monitor thyroid and make sure that thyroid is being managed well during pregnancy and postpartum. When it comes to supplements, because herbs are a little bit more tricky, a lot of times in my practice, I will go more towards glandulars or actual medication.
Okay. So don't you think oxytocin would be a great marker for Precision Analytical to add to their testing? I have someone asking, I personally think it would be a great thing if we added it to our panels, but I do have someone asking, how do you find out if you've got low oxytocin or your patient does?
I mean, yes, Amy, I agree. That would be a great consideration. I mean, you could do serum draws of oxytocin as well. Obviously, like if you're in a hospital delivering it, it may be more realistic to do that, but it depends on what you have access to. And if we were to add it into the Dutch test, you could possibly get it there. Yeah.
Maybe that'll be coming in 2021.
Ooh, exciting.
So in your practice, or just in general, maybe even in research that you've come across, do you find that non-breastfeeding mothers are more susceptible to postpartum depression?
It's variable. It depends on why they're not breastfeeding. Is it because they're not breastfeeding because they couldn't make milk, or is it because they're working, right? So I think it depends on the cause of not breastfeeding, but I think it also depends on their village, right? Like it really depends on who's there to help support them with that too. So it's variable.
Okay. So here's another one on supplementation. Is it safe to give 5-HTP while breastfeeding?
So I will tell you what I do in my practice. Again, any supplements you want to keep at a physiologic dose. And so
on your answer, can you kind of wind in there a little bit about oral progesterone as well?
Oh, sure. Yes.
Okay.
Yes. So 5-HTP, I think you can start at gentle doses, especially if mom is struggling. And in my practice, I don't have a problem starting out with lower doses of 5-HTP because I'm not doing super physiologic doses. And I do want that serotonin support. Oral progesterone, as important as it can be, one of the things to remember is if you're giving progesterone, it will signal back to prolactin that progesterone is increasing, so prolactin may decrease, which may affect nursing. So again, you have to assess how important is nursing, how important is mom's mood. Now, if I have somebody that is severely depressed, I don't care. They're going to stop nursing and we're going to give them what they need. We're going to talk through that because I want to make sure that mom does not further spiral down. Like mom's health is going to be more important and baby will be okay.
Yep.
Yeah.
But this sounds like an interesting case. I have a pregnant client now who has PCOS. She's 29 weeks pregnant. Should we test her hormones now or wait until after birth?
Well, we know that her estrogen and progesterone are going to be high. Her cortisol is probably going to be high. I would still think, because of PCOS and testosterone correlation with postpartum depression, and even just looking at other possible risks for her, not a bad idea to do a testosterone check for her. Not a bad idea to see where her cortisol is right now. And then you could test after birth too.
So this is a pretty broad question, and you probably can give a pretty good quick answer. Does the Dutch test apply to postmenopausal women?
Yes,
Which absolutely it does.
absolutely. Yes.
Okay, I've got another, this is kind of an interesting question. One of my IFM faculty NDs stated that he doesn't check hormones in a perimenopausal woman due to the hormones moving around so much day to day. Would that be the case, the same similar type of case with a postpartum pregnancy patient?
I don't think so, because as much as I agree that perimenopausal females have significant variances with their estrogen and progesterone, with postpartum, it's likely not going to be as variable for as long. And if you have somebody that's struggling, right? Like if you have somebody that's postpartum, but they're not struggling, maybe you don't need to check those levels, right? But if you have somebody that's struggling, I want to test. Why are they struggling, right? Is it because their kynurenate is high? Are they struggling because their melatonin is low? Are they struggling because their cortisol is low, right? Even with perimenopausal females, I want to know what's happening with their testosterone. I want to know what's happening with their melatonin. I want to know what's happening with their cortisol picture. I want to know what's happening with their detox pathways. As much as I know, yes, estrogen and progesterone are going to be variable, I'm still going to want to test.
Yeah.
Same thing with postpartum and postpartum depression. I want to know what's happening with their thyroid. I want to know what's happening with their cortisol. I want to know what's happening with their nutrient status. Absolutely. Testosterone, yes.
So is there anything in your sort of your toolbox when you're diagnosing postpartum depression, how you might differentiate that it is postpartum depression versus just struggling to adapt to be a first-time mom? Is there anything else outside of maybe testing and obviously questions and just being connected to your patient? Is there anything else, any other tools you have in your toolbox?
That is a good question. I do have a lot of conversation with my patients. So I think really outside of testing, it's really about checking in with your patient, right? So if you're concerned, even if they're not recognizing postpartum depression, as a provider, if you're concerned that, ooh, right, like, my ear is tagged because of something that I heard previously, or just listening to what's happening when they come in to see you, I'm going to have more frequent visits with them to evaluate what's happening for them. And I'm going to be really honing in on how is your mood? How is your support network? How is your sleep? What's happening with your cycle? Are you nursing? How is your bonding with your baby? What's going on there? And I'm going to do that more frequently. It's probably going to be super annoying because mom already had, right? They have, their 6-week visit, their 8-week visit, their 12-week, like they have all the, baby visits, which parents usually never skimp on, but that's where mom ends up being like cast aside. And that's when we need her to be a priority. And so I'm going to want to see her more consistently and really have that discussion, not about baby, because baby gets attention from, pediatrician. We need to focus on mom. And so that's what I would do. And a lot of times it's not a bad idea to say, hey, why don't you have your partner come in with you?
Right.
And so because a lot of times I call the partner the honest button, right? Because anytime they come in with somebody, they kind of tell on the patient, right? They're like, oh yeah, I'm sleeping fine. They're like, no, you're not, right? And so the patient, right? So the patient, their objective view might be different, right? So if their partner says something differently, that's going to be important as well.
Right.
So I encourage that too.
And that's a good idea because you're exactly right. They are the honest ones.
Yeah. Yes.
So how long post miscarriage would you wait to run labs on a patient?
I would usually, depending on emotional response, you can wait till the next cycle. If we're working on other emotional responses because of the miscarriage, I'm probably not going to do a lot of hormone testing until they are emotionally ready. But if they are emotionally okay to do it, I would go their next cycle.
Okay.
And that's going to be
keep going.
And that's going to be a pretty important conversation to have, right? Like some people will struggle significantly emotionally through that. And it's like, you know what? let's not even focus on your hormones right now. Like, let's just focus on getting you healed. And then we can look at the hormones.
Great. So, so in your practice, and even maybe in reviewing Dutch results, you know, Dr. Rice is one of our reviewers. She talks to a lot of practitioners every single day. Are there any different levels of postpartum depression that you've seen? And can you tell by looking at Dutch results sometimes what that severity of that level might be?
I will say you can tell, like, just in looking at things, like if certain test results were to come up, I would probably ask, like, oh, how's her mood? How is she sleeping? You know, like, what's going on with that? It may not tell the severity though. So like, you may have somebody that has low cortisol, but they're, you know, they're doing okay, but struggling. And then you have somebody else who has maybe the same type of cortisol presentation, but they're really struggling. And that may have to do with their support network or their socioeconomic status or other things that are going on. So I think that the test results do kind of hint towards that, but it may not fully tell you the intensity or the severity of actual postpartum depression.
Okay. All right, I think I've got time for one more question. I'm looking through here. I know we have so many here, everyone. I apologize, we can't get to every one of them. Let's see.
And if anybody knows anybody that wants to start a whole research section on this, I would love to have that information.
Right, exactly. I think there's a lot that we could.
So much that needs to be studied.
So we'll make this our last question. I don't think I threw this at you earlier. Can thyroid levels return to normal postpartum without any treatment?
They can. Yeah, they absolutely can. But you want to be checking that, right? You don't want to just assume that is going to happen.
Yeah.
Yes.
Yep.
Yep. I would say in general, most of my patients, if they've had a baby, whether they're at risk for postpartum or not, I am checking their thyroid at 6 weeks.
It's okay. It's all part of the whole picture that you do at 6 weeks.
Yep.
All right.
Yep.
All right, everyone. That is our last question. I want to thank everyone again for joining us this afternoon. This was a great webinar. I think super informative. I can tell with lots of questions we have. I think that we've got opportunity to offer probably some more on this subject matter for everyone out there who tuned in. Just as a reminder, we will be sending the on-demand recording to you tomorrow, probably a little bit after lunchtime, West Coast time, along with the slides, and we'll make sure you get that link so everybody can watch the video. And we apologize.
Oh, yeah, I'm so sorry about that.
That did not work. So thanks, everyone.
Thank you, everyone.
Thanks, Dr. Rice.
Thanks, Amy.